Hello, and welcome to your lecture on Intrapartum Complications. The previous lecture on intrapartum and intrapartum nursing care reviewed the normal process of pregnancy, and today we're going to discuss what can go wrong. So we're going to look at some various complications, such as preterm labor, premature rupture of membranes, whether it's preterm premature rupture of membranes or just premature rupture of membranes, dystocias, different procedures and management of these aspects, and obstetrical emergencies. So we'll start with preterm labor. Preterm birth is any birth between 20 weeks and 37 weeks. So as soon as you hit 37 weeks, you are term. So 20 to 36 and 6 is considered preterm. This affects about 12% of all pregnancies. This number is actually increasing as we do more things such as in vitro fertilization and fertility treatments. And the thought behind that is that most of the time, if a woman is having a difficult time getting pregnant, that her body is not actually able to sustain the pregnancy, which is why she's having a tough time getting pregnant in the first place. So a lot of in vitro fertilizations end up in some sort of preterm labor, either because the body isn't able to sustain the pregnancy or because it's a multiple gestation pregnancy, in which case it's more difficult to bring to term. It's definitely possible. It just has a lower rate of term. Some risk factors are infection. If there's an infection present, all right, I'm going to clear my throat. Sorry, if there's an infection present, then the body actually goes into labor because it's not a safe place for the baby. And when I say infection, I don't mean a cold or the flu, but if there's a significant infection to where mom's body is having a tough time sustaining mom and baby, then she will go into labor. Or if it's an infection that could potentially affect the baby. So if there's some sort of chorioamnionitis or other infection that is present in the uterine area and in the amniotic fluid or the chorion or the amnion. And non-Caucasian is a risk factor as well. This is because the level of prenatal care is lower in non-Caucasian individuals. I already mentioned multifetal gestation. So multifetal gestation puts more of a stretch, if you will, on the uterus, and sometimes leads to preterm labor and preterm birth because the uterus isn't able to go that large. Second trimester bleeding is an indication of preterm labor and a risk factor to that the mom will go into preterm labor, and that it relates to irritability. When the uterus is irritated, it will start to contract. And if there's bleeding, then there's going to be pressure on various parts of the uterus, which is going to irritate the uterus. Low pregnancy weight, and that just has to do with the body not being able to sustain both the maternal needs and the fetal needs, so it ends up in preterm labor. And any woman who has a prior history will have an increased risk for preterm labor with subsequent pregnancies. So we've discussed the risk factors. Now let's look at some of the causes. So preeclampsia, and this could be either cause for preterm labor or preterm birth. So preeclampsia again, we have the situation where the body's not functioning appropriately. Typically, there's a preterm birth, not because they've gone into preterm labor, but because the risk-benefit ratio to keeping mom pregnant has tilted into it's more risky for mom's life than it is for the baby's life. So for instance, if we have a mom whose pressures are 200 over 110, and she has a significantly elevated protein creatinine ratio and significantly elevated ALT and AST, and her platelets are going down, we're going to need to deliver that baby regardless of what the gestation is, because mom's life is at risk. And so we're able to sustain the baby if it's past 23 weeks, and we will deliver the baby at that point if mom's life is at risk. Fetal distress, this is also a preterm birth situation to where the fetus is in distress and the baby's going to do better outside than inside. Sometimes we see that with IUGR and the intrauterine growth restriction, and we might see what's called absent end diastolic flow, for the baby's heart is not pumping appropriately. So it's better to have the baby on the outside where we can manage those situations. And then in IUFD, if the baby passes in utero, we will deliver the baby after it has passed, regardless of how many weeks mom is. Abrupto placentae, so if the placenta abrupts, we're going to deliver the baby early because that's a risk for the baby. If there's an abruption, the baby's not getting any blood flow, and we need to deliver the baby. The baby, again, will do better outside than it is doing inside without any blood. If it's a full abruption, the baby has about 3 minutes to be delivered before the baby will pass away due to lack of oxygen and blood. And if the placenta, depending on where the placenta abrupts, the baby might extenuate into the uterine cavity because the blood flow from the baby is going into the placenta, and the placenta isn't exchanging, so the blood is not going back into the baby. RH sensitization can cause anemia in the baby, and the baby might need to be delivered early because of that. Gestational diabetes, or any type of diabetes, which again can lead to some congenital malformations if the mom doesn't have good blood glucose control, and there's certain situations where it might have some sort of cardiac defect where, again, we're looking at that end diastolic flow, and we're going to be doing Doppler studies for the baby to determine whether or not the baby is thriving in utero or whether it would be better outside utero. And renal disease can also be a problem for preterm birth and preterm labor. So 50% of those having a preterm birth do not have any risk factors. So sometimes things just happen and we don't know why. Again, if we knew what started labor, we would be so incredibly happy. We could replicate that and we could stop it. For preterm labor, the only definite cause is infection. We know that infection causes preterm labor. So that's something that we always treat a preterm labor patient with antibiotics, because we know that the body is trying to sustain, and it cannot sustain both mom's life and baby's life. So it's deciding to deliver the baby so that both have a chance. So if we're able to treat the infection, we're typically able to stop the preterm labor, and mom typically is able to carry that baby to term, which is fabulous. So some of the tests that we'll do with preterm labor patients is cervical length. So we can do a transvaginal ultrasound and take a look at how long the cervix is. And this tells us whether or not the baby is coming, essentially, and what the chances are that the contractions that mom is experiencing are going to lead to birth, or whether they are just uterine irritability, because we can have contractions with uterine irritability that don't cause cervical change. And we can have contractions that do cause cervical change. So we're going to take a look at our cervical lengths and we're going to compare them. Typically, if we have a preterm labor patient, we're going to be doing cervical lengths every 3 to 4 days to see if the cervix is getting shorter. So we can decide whether we're in labor or not, or whether those contractions are causing cervical change or not. There's another test that we can do that's not listed here. I'll list it on the PowerPoint that I post for you to print out. And it's called a fetal fibronectin, FFN. What I want you to know about the FFN is that it's a fabulous predictor, negative predictor of preterm labor. So what we do is a sterile speculum exam, and we swab the cervix. We actually swab the posterior fornix of the cervix, and we test that, and it's looking for fetal fibronectin. If there's fetal fibronectin present, there's a small chance that mom will deliver within the next 2 weeks. If there's no fetal fibronectin present, there's a 99% chance she will not deliver in the next 2 weeks. So it's a fabulous negative predictor of preterm birth. The thing with it, though, is that we can get a false positive if mom has had intercourse, or there's been pretty much the question we ask, has there been anything in the vagina in the past 24 hours? So intercourse, have you been checked by a provider? Have you had an ultrasound, a transvaginal ultrasound, or anything else? Because if anything has touched that cervix prior to that cotton swab in the previous 24 hours, we're probably going to get a false positive. So we want to vet our patients and make sure that we are truly assessing what their practices and what's gone on with them in the past 24 hours, so we can determine if the FFN is going to be an adequate assessment test for them. If the mom has a positive FFN, it depends on her gestation, and we'll most likely admit her and watch her closely so that we can determine whether or not the preterm labor symptoms are continuing. Activity restriction is usually put into place. Bed rest is not proven to work, but it causes physical and mental distress. Really what we want is pelvic rest. So no sex, no playing, nothing like that. That's what's going to be the most beneficial for mom. Remember, the hormone of orgasm is oxytocin, which is also the hormone of labor. So in a woman who's at risk for preterm labor, we don't want any additional oxytocin being released. In addition, the sperm and the semen acts as a prostaglandin on the cervix, so it softens the cervix. So we don't want that for a woman at risk for preterm labor. If she's not at risk for preterm labor, not experiencing preterm labor, all is fine, and it's not going to throw her into labor. It's just those women who are experiencing preterm labor already that we're going to recommend pelvic rest and activity restriction. I think the activity restriction just makes the providers feel better that mom's not up running marathons or something like that. But again, it's really mentally challenging for a mom to be stuck in bed. And most of the time, can you imagine this mom who has 2 or 3 other kids at home, or even just one other child at home, and they're either on bed rest and activity restriction and having a tough time caring for those other children at home, or they're stuck in the hospital and not able to care for those children at home. So it can be very deflating, and we can have some significant mental and psychological impacts that we need to deal with. I mentioned before that preterm labor is typically caused, the only definite cause is infection, so we do give antibiotics. We will usually, if it's preterm labor, we'll just usually give one course of antibiotics and see where we are after that. We'll give antenatal glucocorticoids, which is going to be betamethasone, and we either give 2 shots of betamethasone, it's 12 milligrams of betamethasone 24 hours apart or 12 hours apart, depending on the risk of the delivery. The betamethasone helps to kickstart the baby's lungs into developing surfactant, so they're able to keep their alveoli nice and open and do that gas exchange. So it's really helped significantly with respiratory distress in preterm kiddos. Some of the tocolytics that we use include mag sulfate, terbutaline, nifedipine, and indomethacin. Mag we will give as a tocolytic. That's kind of an off-label use. However, remember that mag is calming. It's a parasympathetic activator, so it's going to calm the uterus as a nice little side effect. It's also going to bring blood pressure down. And the other fabulous thing that it does is it provides neuroprotection for the baby. So if we have an imminent preterm birth, we're going to give mom a bolus of magnesium sulfate, probably give her 4 grams over 20 minutes to an hour, just depending on the doctor's order. And what this is going to do is help to reduce the excitability of that preterm baby's brain. And it's going to reduce the number of seizures the preterm baby has, because that's a risk factor for preterm birth, is these little ones have seizures, which impacts the developing brain and can cause brain damage and can cause bleeding and all sorts of other things. So we've had significant success with administering the magnesium to mom if a preterm birth is imminent, and reducing the excitability of the preterm baby's brain and able to reduce seizure activity significantly, and in most cases down to 0, which is fabulous. Terbutaline is a beta adrenergic drug, and it's also going to relax the uterus. We want to be careful with the terb though, because it's going to increase the mom's pulse. So if mom is already tachycardic, we're not going to give terb. So anything over 120, we probably wouldn't give the terbutaline, just because mom's heart rate is going to go too high after that. Nifedipine is a calcium channel blocker, and nifedipine helps to relax the uterus as well. Nifedipine is something that we give as kind of around-the-clock medication, a scheduled medication, and we typically have a PRN dose available as well to stop the contractions. And then indomethacin is an NSAID, which we're going to be careful, because if the baby is less than 32 weeks, we can cause a closure of the PDA because it blocks the prostaglandin production. However, it's great at stopping labor. We usually give a dose of 50 milligrams first, and then the next, I believe, 6 days, they get 25 milligrams. So we just have to do our due diligence and ensure that we're giving the appropriate tocolytic based off of the mom's current state and history. So other than preterm labor, some other problems that we come across would be PPROM. And I see that there's an error there. It just says PROM. So PROM is premature rupture of membranes. What PROM means is that the water broke before contractions, before labor set in, which typically doesn't happen. Typically, you're in labor for a long time and your water breaks. Every once in a while, I think it's probably about 15% of people, their water breaks, or 15% of births, their water breaks, and then they go into labor later. So that's PROM. PROM is a term, would be for a term pregnancy. PPROM, and again, I will change that for the PowerPoint that I attach as just a PowerPoint for you to print out. PPROM is preterm premature rupture of membranes. I'll say it again. PPROM is preterm premature rupture of membranes. We treat it the same as preterm labor, but these mamas get to be on long-term antibiotics. And as soon as it's identified, they get to stay in the hospital until about 34 weeks. At 34 weeks is when the risk-benefit ratio swings to being more risky to keep mom pregnant for risk for infection for the baby than it is to deliver the baby at 34 weeks. So PPROM patients, we're going to put on antibiotics. They're going to stay on antibiotics. We're going to be very diligent about peri-care, or teaching mom to do her peri-care. She's going to be admitted to the hospital, and she's going to stay pregnant until about 34 weeks if we can keep her that way. And we'll deliver the baby around 34 weeks. A dystocia is any dysfunctional labor, whether preterm or term. It happens in about 8 to 11% of all births. And a dystocia is going to be a problem with one of our Ps. Remember our 5 Ps from the previous lecture? So something's going wrong with our labor, and one of the Ps isn't functioning appropriately. So we have a dystocia. We could have hypertonic versus hypotonic uterine activity, which is going to be either too many contractions or not enough contractions to create the cervical change that we need. Or in the case of too many contractions, then we're going to probably create distress in that fetus, and so that's going to cause a problem as well. A pelvic dystocia is the least common, and this is due to neoplasms or spinal disorders. So they're just not able to adequately birth the baby. CPD or FPD, CPD or FPD is cephalopelvic disproportion or fetopelvic disproportion. And this is our giant babies, so macrosomic babies, or a baby who is asynclitic or malpositioned. So if we have a face presentation, the baby isn't going to be able to perform those cardinal movements to come to be birthed. So there's certain presentations that even though that baby is head down, we're not going to be able to birth the baby vaginally. Sometimes we can get the baby to move. Unfortunately, we typically don't identify those presentations until the baby is so engaged in the pelvis that we can't manipulate the baby's position any longer. In cephalopelvic disproportion, some of the signs of having CPD, that the baby's too big to pass through mom's pelvis, are slow cervical change. So if we have a significantly prolonged labor, we're going to consider a CPD risk. If mom has diabetes, specifically gestational diabetes, we're going to consider a CPD risk. In labor, if we have a dysfunctional labor pattern, so if we have contractions that are clumping together, either coupling or tripling, and then a long pause after that, and then one contraction, then we have coupling or tripling again, we're going to consider a CPD risk. And if we don't have descent, so if mom's cervix opens up nicely and effaces and dilates, but the station of the baby isn't changing, that's also going to be a sign for CPD. Another thing that we typically see in big babies as a symptom that where mom complains of significant back pain. So that can be a sign that the baby is occiput posterior. We discussed that in the positioning aspect of the last lecture or of the intrapartum lecture, or it can be that the baby is significantly large and putting a lot of pressure there. So with CPD, we'll give mom a chance, and then if it's not working, we'll perform a C-section. Meconium. So the baby's first stool is called meconium. Meconium is sterile because remember, baby's gut is sterile, and it's very tarry. It's pretty much made up of just broken down red blood cells. And what the problem with meconium is that if the baby has passed meconium, it's for one of two reasons. Either the baby is post-term and there's just so much meconium in the rectum that the sphincter releases, or there's been some sort of assault on that kiddo at some point to where the sphincter released as a response to that assault. So there was something that the baby didn't like that happened. So one aspect of our concern is that we don't know what that assault was or if there was an assault. So if we break mom's water and we see meconium stained fluid, we're going to be vigilant at delivery because we want to know if or we want to be prepared for a baby who might be compromised due to whatever assault occurred. The other thing that we're concerned about is that the baby has this fluid is through the lungs and through the mouth. And although the meconium itself doesn't cause a problem, it leads to aspiration pneumonia and therefore respiratory distress. So we're concerned about it from a respiratory standpoint for aspiration pneumonia, and because we might be having a compromised baby due to some assault that occurred. So we're more vigilant for births where we see meconium in the fluid. So some of the things that we can look at is for our procedures and our management. Here we have a baby, and we can see that the provider is performing an external cephalic version. What we do here is the provider does an ultrasound. Depending on how many weeks mom is, we might actually give her an epidural, because a lot of the time we do the version, and if it's successful, we'll induce her right then and there. The version is painful for mom. It's not a comfortable experience. So if she's planning an epidural, sometimes we'll give that to her first. And then we give her some terbutaline to completely relax her uterus. And the provider attempts to flip the baby. Different providers have different success rates, and it depends kind of on the shape of mom's uterus and all sorts of different factors. So the success rate of versions ranges from 10 to 75%. You don't need to remember that. It's just a huge range. So, but just know that it's a process that we can do and that we offer moms who have a breech baby. We'll offer to try to turn the baby. There are some risks associated with this, though, in that in turning the baby, you can imagine that the cord might get tangled, or depending on where the placenta is, we might cause a problem there. So we're going to be monitoring the baby before and after as well. One of the other things we look at is induction versus augmentation of labor. So an induction is where we provide medication to mom or some sort of intervention which is going to start her labor. And augmentation might be those same exact medications. However, mom is already in labor. So mom comes in and she is already changing her cervix or already contracting, or her water has broken, and we're augmenting her labor. Whereas induction means mom walks in completely comfortable, not contracting, no cervical change, bag of water intact, and we start her labor. Some indications for induction would be postdates, PIH, preeclampsia, sometimes gestational diabetes if it's not well controlled. IUFD, we would want to induce for the baby if the baby has passed away. And postdates is probably our most frequent induction. And more facilities are pushing back the time frame that they'll induce for postdates, which I think is fabulous. Legally in California, we cannot induce before 39 weeks unless there's a medical indication. Some other medical indications would be autoimmune diseases, cholestasis, health problems for mom. So there's a variety of things that would indicate we needed an induction prior to 39 weeks. But if the mom and baby are healthy, then we cannot do elective inductions before 39 weeks. And I know, for instance, at Kaiser, we don't do elective inductions at all. So if mom is not at least 41 weeks, we will not induce her. A risk factor, though, that can be utilized is AMA, advanced maternal age. So if mom's over 35, that counts as a risk factor to induce prior to 39 weeks. Physicians are more and more seeing that there's not a benefit to either the mom or the baby to induce earlier than 39 weeks, though. If mom hasn't already gone into labor, her body's not ready, and it's going to take a long time. And those inductions, those early inductions often end in a C-section because mom's body just wasn't ready, and no matter what we do to it, it's still not going to birth that baby. And then we have a baby who could potentially have a more difficult time transitioning as well if it's earlier on in gestation. So luckily, we're not seeing many of those anymore. Bishop score is something that we take a look at, and look that up in your book to see all of the various aspects that we look at. But what Bishop score does is tells us the likelihood that this induction is going to be successful. So it takes into account some various things, including the cervix and the gestation and stuff, and it gives us a score to tell us how likely this induction is going to be successful. So how are we going to induce mom? So cervical ripening methods include prostaglandins, which is going to be either Cytotec or Cervidil. Cytotec can be administered cervically, like right up against the cervix, or buccally in the cheek, and it helps to soften the cervix. We need to soften the cervix before we give Pitocin to open it up, because otherwise we're just going to be pulling on something that's not wanting to open. Think of a prostaglandin as a key. It's going to unlock the door, and once that door is unlocked, it's pretty easy to turn the knob and open it. But if that deadbolt remains, you're just going to be pulling on that door and it's not going to open. So it's the same concept. Cervidil is a longer acting prostaglandin. So the Cytotec, we're going to give every 4 hours, essentially. If we have some checks that we're going to do, make sure baby's coping, make sure mom's not contracting too much, make sure we're going to check her cervix, but we can give the Cytotec every 4 hours. The Cervidil is the patient receives that once, sometimes twice, but it's only every 12 hours. And Cervidil is impregnated on a little string, and that string goes up next to the cervix and again helps to soften the cervix. Mechanical would be a Foley bulb or cervical ripening balloon, which a Foley bulb would be the end of the Foley. It looks just like a Foley, even the cervical ripening balloon. The cervical ripening balloons just have 2 balloons instead of 1. So there's a space in between the balloons. And what happens is the end of the Foley goes up into the cervix, and we blow up 1 balloon. So there's 1 balloon inside the uterus, and there's 1 balloon on the outside, and that kind of squeezes the cervix, which enhances the release of prostaglandins and mechanically pushes on the cervix. Sometimes we'll provide traction by hanging a 1,000 milliliter LR bag from it as well. And then an amniotomy is breaking the water. So this is a great technique for induction or augmentation for multips. So moms who have had a baby already. This allows for the release of prostaglandins and allows the baby's head to come on down, which that pressure on the cervix is going to help open it up. We don't want to do this too early though because of the risk for infection. Pitocin is another way that we utilize or that we induce or augment labor. So if a mom is having her, let's say, second kid and she's already dilated a little bit, nicely effaced, but she's not in any sort of regular contraction pattern or contracting at all, then we would probably start with Pitocin. We typically choose the cervical ripeners if mom is less than 2 centimeters, 2 centimeters or less. Once she's 2 centimeters, we're going to move on to Pitocin. It's the synthetic form of oxytocin. We started off really slow. So it's given in milliunits per minute. So we are going to give it very slowly and give minute amounts. The good thing about Pitocin is that it's very short acting. So you can see here, dose-related harm. So if we give too much Pitocin, we can cause tachysystole. So we want to be sure that we are watching our baby very closely. We're monitoring mom very closely, and we're monitoring the uterine activity very closely so that we're not providing an environment that is going to be harmful to the baby. With fluid overload, we just want to be careful because when we give Pitocin, if we get mom or baby into a fetal distress situation, then one of our primary intrauterine resuscitation interventions is to give LR, and we open up the LR. So sometimes women who are on Pitocin end up in tachysystole frequently and end up getting more LR and end up with fluid overload. So moving on to some birth complications and birth procedures. So if mom is having a difficult time birthing the baby, but the baby is low enough, the physician will assess mom for an assisted birth. They can assist either via forceps or via vacuum. Maternal exhaustion is a significant cause for the use of forceps and vacuums. Sometimes they will choose that a C-section is what's needed just because they feel like this baby is not going to fit, and that's why it's working, and that's why it's not coming down. But physicians who are skilled in forceps can utilize forceps. There's some risks to the baby though, and risks to mom. Mom's probably going to have a little bit more of a tear than she would have had or the physician might need to cut an episiotomy to allow for the proper positioning of the forceps. We might see a facial palsy in the baby, or hematoma. There could be some urinary retention on mom's part, or hematomas on mom's part. So they're not without risk. However, they can be significantly beneficial for a mom who's just completely pittered out. If she's been pushing for 4 hours, she got the baby all the way down, the physician can help her just a little bit. With both forceps and a vacuum, mom still needs to push incredibly hard. It's just that the physician can help her a little bit. So this is what the vacuum looks like. The vacuum, in all honesty, takes a little less skill for the provider than forceps do. Forceps are an art in the vacuum you just kind of put on. You want the placement is very important, but it's not quite as skill-based as the forceps. Some of the same risks are there, though. So you can see it kind of suctions the baby's head. Vacuums and forceps alike are also very good for babies that might be like direct OP. So you can see in this first picture here, this kiddo's face up, right? So those kids are so hard to push out, but they were able to turn the baby with the vacuum and then mom can push the baby out. So sometimes it's just a positioning thing that the physician is able to assist significantly with the vacuum and the forceps. Mom has an increased risk for a significant laceration, hematomas, urinary retention, and the baby's at risk for hematoma and scalp lacerations as well. So if we're not able to get the kiddo out vaginally, or if it's too much of a risk for mom, we're going to do a C-section. This horizontal in B here is the more likely aspect that we are going to utilize. It's called a bikini cut, and we call it bikini cut because it's covered by the bikini. It's very low, it's small, and there's very few things that wouldn't cover it. A vertical line is obviously a more significant C-section here, more significant scar. A uterine incision is going to have an impact on mom's future births. So if we have this low transverse uterine incision, then mom can attempt a vaginal birth in future pregnancies. And you can see how the low transverse incision goes along the line of the muscle to where the vertical incision, and this vertical incision is in the lower uterine segment, and this vertical incision is spans the length of the uterus. But the vertical incision goes against the grain, if you will, the direction of those muscle fibers. So their mom will need to have C-sections from that point forward if she has either of the vertical incisions, because she would be at an increased risk for her rupture of her uterus. But the low transverse, we can, even if she's had two, we can let her labor and see if she can have a vaginal birth after cesarean section. So why would somebody do these vertical incisions when this is a much safer option? It has to do with a couple different things. One, this takes time, and it's not as fast to get the baby out. So if we are having a true obstetrical emergency and the baby needs to be delivered like 10 minutes ago, we are going to do this, or the providers are going to perform a vertical incision. And the baby is able to be delivered much easier and much quicker. We might also do a vertical incision for significantly preterm babies, and that one would be performed just in this lower uterine segment, or depending on the location of the placenta, or if there is some sort of placental problem such as an increta, procreta, or accreta, then the vertical incision might be performed as well. With sorry, I lost my train of thought. That's okay. So what are they moving down here? They're moving down the bladder. So this is called a bladder blade. And what they do is pull down the bladder to expose the uterus here. Currently in the US, the C-section rate is about 33%. We're trying to get that down to 25% or below. Our area hospitals in San Diego area are doing a really good job with that, and significantly reducing their primary cesarean rate. One of the ways that is really impacting that is what we discussed earlier with extending the time for when we would do elective inductions. So really pushing that back to 41 weeks or beyond has had a great impact on our C-section rates. So looking at the skin incision versus the uterine incision, we're going to want to ensure that we have adequate records of what type of C-section mom has had, because we can have a low transverse skin incision and have a vertical uterine incision, or vice versa. We could have a vertical skin incision and a low transverse uterine incision. The skin incision does not impact whether mom can have a trial of labor, just the uterine incision. So we're going to need adequate medical records. If we don't have that, we're not going to allow her to labor because it's not safe. Because if she did have this type of incision, the vertical incision, then it's going to impact her risk for uterine rupture. So here's some pictures of a C-section, and hopefully the majority of you will have the opportunity to view that. And there is a video online as well, but here's just some pictures of what's going on. So moving on to our next lovely dystocia and emergency, a shoulder dystocia. So as you can see from this picture here, a shoulder dystocia is when the baby's shoulder, the anterior shoulder here, gets stuck behind the pubic bone. So there's a few things that we can do to help this. And it is an emergency because the baby, once the head is delivered, the cord is being compromised and the baby's being compromised, and we can have a brachial plexus injury, and we could have neurological damage. So once we identify that the shoulder is not delivering, we're going to act very quickly. One of our ways of acting is going to be McRobert's maneuver. So that opens up the pelvis. You can see here, we're going to pull those legs all the way back. We're going to lower mom's bed down completely flat, and we're going to pull her legs back as far as they will go. And although this picture shows mom doing it, really you have a nurse on either side just pushing her legs back as far as they can go, which gives you a significant increase in the space for the baby to come out. We're going to try that. If McRobert's doesn't work, we're going to move on to suprapubic pressure. Now, suprapubic pressure is a intervention that actually requires a physician's direction. So me as the nurse cannot choose to do suprapubic pressure. The way that usually works out is we've done McRobert's, mom's pushed. It's very loud in these rooms when we have a shoulder dystocia. Tons of people are screaming at mom to push harder, harder, harder. And if, say, I'm the primary nurse, I just look at the doctor and I say, would you like suprapubic pressure? And they say yes. and we move forward. It's very quick. It's not a huge process, but it has to come from the doctor. It's not a decision that the nurse can independently make. With the suprapubic pressure, you can see that we push down into the side, and we're pushing in the direction. You can see that the provider's hand is pushing this way, and that so is the nurse's hand. And so the idea is that we'll be able to rotate that shoulder a little bit and pop it under that pubic bone. About half of all cases of shoulder dystocias don't have any risk factors, and we don't suspect them. And so that can be kind of surprising. So we need to be ready for shoulder dystocia at every single delivery. So we have stools available in all labor rooms so that we can hop up to do that suprapubic pressure. Typically what happens is the stool is more of a stepping stool onto the patient's bed, where the nurse either straddles the patient or sits on the bed and pushes as much as she can, because you can't get quite the right traction with just standing with the stool leaning over. In these situations, the nurse needs to be kind of aware of her body, though, because a lot of nurses get significantly injured in shoulder dystocias. Again, some of the complications are a brachial plexus injury, in other nerve injuries. Brachial plexus has an 80 to 90% complete healing rate if we have early intervention and early identification. We are going to bring the NICU team to any shoulder dystocia delivery so that they can adequately assess that baby once it's born. Some other things that might happen is that the humerus or the clavicle might get broken in the process. The physician can try to deliver the posterior shoulder first, which in some cases ends up breaking the arm, or the physician might choose to break the clavicle to deliver the baby, because the broken bone is easy to heal. Neurological damage is not. Another true obstetrical emergency is an umbilical cord prolapse. With a prolapse, the umbilical cord, you can see, ends up being it falls out of the uterus before the baby. The risk here is that the cord gets compressed up against the cervix and between the cervix and the presenting part. So if a prolapse is identified, the way we deal with that is that we, either a nurse or provider leaves their hand in the vagina and relieves the pressure off the cord. So the cord ends up being between two fingers, between the head and the vaginal wall. It's very challenging physically to hold that position with your finger strength. Fingers aren't that strong. The nurse stays on the bed. She gets to roll down to the ER with the patient, and OR. She stays under the drape until that baby is delivered. So it's, again, significant hand cramp after an umbilical cord prolapse, but she just saved that baby's life. Because if we're not relieving the pressure off that cord, the baby has less than 5 minutes before significant neurological damage occurs. We can usually get a baby out within 5 minutes, but it's going to be a much safer C-section, and the baby will do much better with the pressure being relieved off the cord. So here's a picture of those interventions. And if mom suspects a cord prolapse and there's not a provider, this is kind of how we educate mom to take some of the pressure off that cord. Because if mom goes on her hands and knees, then the baby slips back down and the head isn't hanging out on top of that cord. So some other emergencies that are more maternally related than specifically fetal is a uterine rupture. Now, uterine rupture is going to have a significant impact on both the baby and the mom. And mom's going to be at risk for hypovolemic shock and is going to need some significant blood. Another aspect is AFE, which is an amniotic fluid embolism, or ASP, anaphylactoid syndrome of pregnancy. This is essentially the same thing. What happens here is we have a sudden cardiac collapse along with coagulopathy. So we're looking at anaphylactic shock, essentially, due to a foreign substance, which is the amniotic fluid, which is why it's called an amniotic fluid embolism. The mortality rates are 61%, and we're going to see DIC and hypoxia. We're going to want to intubate ASAP, replace the blood losses. We would potentially deliver immediately or potentially wait to stabilize the mom, just depending on what's going on. I actually have a friend who experienced an amniotic fluid embolism, and she was very lucky to survive. The nurses, the only reason AFE patients survive is because of immediate, competent nursing care. So the nurse saves the patient life in every aspect. It's the nurse who typically identifies this because usually the doctor isn't right there on hand, and it's the nursing interventions of starting CPR and calling a code and getting the team there that needs to be there to adequately support this patient that saves these patients' lives. And this friend of mine has a fabulous story, and it's great to hear her talk. And her husband, after this experience, her husband actually went back to school, became a nurse, and now works in the ICU at Scripps Encinitas because he was so impressed with the nursing care. And she started a nonprofit organization that educates OB professionals, nurses, doctors, midwives on emergency care for rare emergencies. AFEs happen so rarely that sometimes they're hard to identify, but it's so important to be identified early on. So that was your lecture on intrapartum complications, and I hope you wrote down any questions that you have, and we will address those in our next face-to-face lecture. Thank you.